Yes. So, thank you very much for the introduction. And sorry, we have to go back to black and white. That's the reason, because we talk about most likely on angiography, because the pictures were really impressive. Coronary compression is one of the complications, or also the limitation which can happen, or which can you try to prevent in regard if you have a patient for PPVI or transcatheter valve implantation. And it's interesting that it is described also that it can be caused by nature in patients where you have an enlargement of the pulmonary trunk, which is not affected or not affected by the stenting in this case. Just the trunk of the pulmonary artery trunk can increase over time, most likely in patients with pulmonary hypertension, with a PDA or whatever, and this can also compress the left coronary artery. In this cases, a number of cases have been described, and it is first described in 1957 that this can happen in patients with the pulmonary artery hypertension. So there are a couple of other reports on that, and most likely also on the therapy, but there's also a knowledge that stenting on the RVOT can cause coronary compression. So that's what we kept in mind as we started with the valve implantation in this region. So the title is Game Changer. What is the game changer? According to a game, somebody is or someone affects the game so that the game is really, or the result of the game is changed. So do we really have this occurrence in regard to the coronary? So is the coronary really a game changer in regard to PPVI? And sure it is, because the expansion of the pulmonary valve region of the RVOT is most likely changing anatomy. And most likely it's happening, or it's happened, that the left coronary artery, which most likely runs below this region, can be affected. But it's not only the left coronary artery. In some of the patients, especially with regard to the cardiac anatomy, it's also possible that the right coronary artery is affected. So both coronary arteries have to be checked in regard to before you expand the valve region of your conduit, of your transannular patch of your RVOT. So it can be maybe assumed, or it can be also tried to be symbolized by the picture which you have from 3D or SCT MRI. But I think really the expansion of this region is sometimes the most difficult thing, and you cannot do it before you most likely have tested this in the cath lab. So the coronary judgment is sometimes be done like by CT scan, by MRI scan, and sometimes the people from the MRI or CT tells you, oh, watch out, the coronary is really near, maybe it's a limitation on that. So that's why you what you keep in your mind before you do the testing of the coronary angio. But sometimes it's different. So the coronary is much far away than you thought about if you see the CT or MRI scan. So I think you cannot rely on this information before you haven't tested it in the cath lab. So there are a couple of modalities. Is imaging first for orientation, and then you do the testing most likely with the ballooning or with just a selective angio before. And I will tell you now where a couple of things are really different and in regard to this testing most likely. So again, you see these pictures here from the implication of the 3D data set. And I think it's a good thing to orientate in these patients, because you see the valve region and the stenotic region somewhere at the point of the pulmonary artery. And below and above, you might see that the coronary artery runs through this region, but the stenosis may be a little below where the coronary runs. So that may be an orientation. You see the right coronary artery, which is maybe not affected in that regard. And if you have the 3 data set, you can also try to orientate the right gones here. You can mark those. You can really highlight them. And you see, yeah, it's below this region where you want to expand, but maybe we can test it, or maybe we can see if this is really effective if we just increase the diameter in this region and not in this region, where this area is still big enough. And if this is not enough, you can just screen through as you do it from lateral view to see also again what is the area and if it's maybe higher or lower in regard to your stenotic region. And if you also have the overlay possibility, you see that the coronary artery can be also mark, as with these rings here, during the intervention, and you can mark your proximal and distal part again with these rings, and to see, you may stay off the region where the coronaries is crossing. And in this patient, we have done the valve implantation, and I think it's quite clear that the area where the coronary runs is a little lower and a little higher than in that region where we expanded the valve, but we also looked for the LAD, and in this case, it was clear and off. And you can see one other thing is what you can try to orientate with is with a wire in position during the selective angio. You see that the tip of the wire, which is running in the direction of the valve, is already off the region where the valve region is. So that's the orientation, a 3D, if you try to combine them to be really safe or sure that you do not compress the coronaries. Simultaneous angio is also the first thing we do because we didn't expand anything in this part over here. And if we do this, we have a good clear picture if we do a selective coronary angio together with the pulmonary artery angiogram. And you see sometimes that it is a possibility to expand the valve or even not. It's a little more complicated on those conduits which are really highly calcified. And as we heard from Peter in the morning, there's a risk of conduit rupture. So if you expand or try to expand these conduits, you may get ruptured. So what's happening if you get rupture, you have to stent it, and you might not be able to stent it. So that's why you try to exclude coronary compression, really restrictive in those patients, sometimes just with the angio, sometimes with a different maneuver, which I show you. And this is the sizing balloon, which can be a testing balloon for that purpose. It's just a really soft balloon, which is just filling out the area where the valve region is and where the conduit. It may shows you the restrictions, and it may show also you the area where you might have your stability for the stenting. But it also should be clear that this balloon is not expanding the conduit in any way as other balloons do. And 3D rotation angio is also sometimes really helpful in those patients where you have overlapping structure of the balloon, which gets bigger in the lower and upper part, and we might really not really good see or have a good clear picture on the coronaries in regard to the balloon sizing. The disadvantage of this balloon sizing with a low compliant or this sizing balloon is that you really don't change the anatomy in this part. The good thing is that you may not rupture any conduit as so. So after you might do the low compliant balloon, you might do a really balloon testing, and in this part you really expand the conduit in regard to what's the size may be which you wanted to end up with the stenting and with the valve inside. So you might head off for this balloon size as big as possible and expanding the valve for the coronary testing. So in this part you simulate what's happening if you stent and the valve is inside, and which is really important on that. In the calcified homografts or conduits, it's really difficult, and I think in this part you have to be really sure in accordance to not most likely expanding this conduit before you are not sure that you can expand it and yet that you are not affecting the left or right coronary artery. And I think that's sometimes where we stop maybe the examination on this part because we are not clearly 100% sure that we can compress the coronary. And also, if you have to expand the valve later on or your stents before you put the valve in, you might check again what's happened from for the distance of the coronary artery to see that further expansion is possible in regard to the coronary artery. And I think that's really for sure. Sometimes if we put valve in smaller kids, we might be also at the border and we might not further expand this region. Here I can show you an example where we have a coronary compression, and again we use the sizing balloon and the low compliant balloon. In this case it's a bib balloon, and you can see we did a selective angio, and the wire is in position to mark out our LAD, and you can see that there is an affecting a part of the balloon, maybe a little lower than the stenosis is, but this part is not that affected by the low compliant balloon, the sizing balloon, but it's more affected by the bigger or more stronger balloon. And I think it's a septal branch, and I wouldn't be maybe it's not really really interfering of the complete coronary perfusion, but maybe this septal branch may be enough for causing any problems. And in this patient, we did also it in the AP, and again, it was visibly that this balloon is interfering with the coronary artery system here, even if it's a septal branch, that may cause differences. And we're not sure. We have to expand the valve overall in the same region over here, maybe lower. We were not sure how deep we have to go in, down there with the stenting, so that's why we excluded this patient, even with the control afterwards, that the coronaries is still the same in this part. And this was the EKG during the sizing maneuver, and I was really impressed by the EKG changes in this patient because we were not clear why we get this change, even if we compress a septal branch. But this happened during the sizing maneuver, and this is something which you not really see. Even we saw that the left pressure or the aortic pressure is not really completely low. So we have some residual flow, which you sometimes not see. As you can see here, we have a patient where we did a sizing here. The aortic pressure is really low because we completely obstruct the right ventricular outflow tract. And we don't see any EKG changes if we do it really quickly, because that's something which also then occurs, that you have a low flow in the aorta. But this is really sometimes telling you, also the EKG can tell you, you might be compromising or have a stress on the coronary system. It's a little easier if you have a biological conduit, which is a really strong ring, as the Carpentier or whatever biological conduits are, Hancock's. And this part, coronary artery, is not effective if you stay inside the conduit, because you will not expand the dimension of the conduit, except you don't do it like Peter showed, that you can also crack those valves with a high pressure balloon to get a more inner diameter for a longer PPVI strategy. So if you stay inside the valve region or even inside the valve diameter, you will not affect the coronaries in these conduits. To be aware, the right coronary can also be affected. It's not always the left coronary artery, so check both coronary arteries. If you have a good imaging, I think you can exclude mostly the right from the imaging before. You see that the left may be near or the right may be near, so this is really something's done. So there are only rare reports on coronary artery compression, and this, what I found is a more actual publication on that, which showed the results from the FDA-trial in the United States, where they had a 5% of coronary artery compression in their patient group. And most likely they told us, or they were writing this in the publication, that it is together with the abnormal coronary artery. So most likely they came from a different sinus than we have expected this, or than they expected this. And it's affecting both left and right, and it's sometimes really something which I was interested in is the number of patients where they screened, even in selective angio's, are really low. So I think this is sometimes maybe different between the centers. I wouldn't do a PPVI without screening the patients. So that's why I just shortly looked up, and I'm able to share our data. How many patients we have screened for PPVI in the last 10 years nearly, and how many patients we have put in the valve. So we have screened 318 patients over all the years, and in 78 patients we didn't put a valve in because of several reasons, but one is in 88%, 28 patients is risk for coronary compression. And the others are sometimes size matters or even other things where we didn't intend to do the valve procedure. In 75% of the patients, we did implant a valve. But we talk about a session and complication. So yeah, it's overall, it's 8.8%. And we just had one patient with a coronary compression in our patients group. This was years ago, and I want to show you the pictures because I think it's good to know those cases, and then you may be really restrictive in regard to not trying to get over the borders for coronary compression and conduit expansions. So this patient had a 60 millimeter conduit in place, and the left coronary artery was also checked, and I think it was carefully checked during the whole intervention because you can clearly see that the left coronary artery, according from the main stem to the LAD, everything is running through under the conduit, and it's at risk. So that's still been checked over all the time at the pre-stenting in this part and after the melody implantation. And I think at this part, the conduit expansion is not that big, and so they tried to do a post-dilation with 20 millimeters then, and the conduit was expanded with the freestanding and the melody valve inside. And still afterwards, the coronaries looked fine. You can see it here. This is the last check-up of the coronary artery. And, but the patient 4 hours later on the normal ward has a VT, or had a VT, and was resuscitated. And this was the angiogram which was done in the operation room, where the left coronary artery was completely away, obstructed or compressed by the stenting. And this was a picture afterwards. It was the stent on the melody was removed, and the coronary artery was recovered, so to say. So in this part, from our patient, we had 1 out of the 370 patients, which means 0.3% coronary compression, but not risk. Risk is 8.8%. So if we really are taking this serious and really make a good evaluation on coronary artery, I think we can prevent this. How this treated? Some have published already just a stent in the LAD, and that's it. It's possible. I'm not sure if this is a good result or if it's a good strategy, but it's published in several things. If the LAD is compressed, you can do it by stenting. I think some will be a little, there will be a point of discussion on that. I think the most important thing is that you avoid it by the screening strategy, and I think you will not really often see coronary compression in your patients. So, in conclusion, it should be avoided, and as I said, and coronary arteries should be really evaluated by imaging, by balloon testing, by simultaneous angio, by 3D angio, by low compliant or more compliant or more effective ballooning, but especially in regard, before you put a stent in, you should try to expand your conduit in regard to the distance to the coronary artery, and then you'll be on a safe side to avoid it. And the only difficulties, I think, is in the calcified homografts or conduits, where we have to try to expand or simulate, and I think balloon testing in those patients is a little more restricted. And it's the risk of compression is low in regard, and I think the incidence of compression is much lower, and the mortality is also much lower in the last 10 years, so I think it's a rare occasion, and hopefully it will stay at this. So thank you very much.